Now, hi everyone, Michelle Lyons back with you again. I always say it, but I'm so pleased to have such learned colleagues on the planet, and thank you to the gods of the internet that allow me to converse with them and connect with them and share their wisdom with you through the power of computers and technology. I'm delighted today to welcome my friend and colleague and author of the Interstitial Cystitis Solution, Dr. Nicole Cozean. Welcome, Nicole. How are you?
I'm doing great. Thanks so much for having me, Michelle. This is really exciting.
Absolute pleasure. So Nicole has really built a stellar reputation as a clinician who specializes in the treatment of interstitial cystitis / bladder pain syndrome / painful bladder syndrome / chronic urological pelvic pain syndrome, a rose by any other name. So many different names, and which I think is reflective of the confusion that there can be around bladder pain syndrome. Nicole, why do you feel like it's such a confusing topic for even researchers and clinicians, never mind the poor patients who have to deal with this?
Yeah, I think ultimately it's because the symptom presentation is so different with everybody, but the overwhelming symptom is always some sort of bladder situation, right? So there's urgency, frequency, or bladder pain, or urethral pain, or pain with urination. So that's always like a hallmark sign. But really what we're finding out with some of the newest research is that it's not about the bladder as much as we once thought. But the whole thing started with knowing and actually seeing that there was a small subset of people that actually had lesions in the bladder, which we now know as Hunner's lesions. But that now is such a small subset of what actually is happening with the condition. Notice I didn't call it a disease. I feel like I call it a condition. But yeah, so I feel like it started out as recognizing what we kind of now in the field know as true IC, right? Which is Hunner's lesions. And then now we kind of have broadened that scope to talk about people with pelvic pain and urinary symptoms. And then that's when they all glob into one category, which is all the other acronyms that you named right there. So, but I feel like ultimately it's because it's a very complex condition with multiple types of symptoms. But the overarching theme for all of our patients is that there's a main huge bladder symptom associated with the condition. So
I suppose, the main characteristics of this condition would be, pain and the frequency, urgency to avoid that pain that sometimes we can associate with bladder filling rather than a fear of leakage per se. I sometimes, I kind of vacillate between is it overdiagnosed? Is it just that we don't know what else to call it, so we're going to call it interstitial cystitis or bladder pain syndrome? Or are there still too many people going under the radar with it as well? And I think particularly men, because this is very much characterized as a woman's disease, and women do make up the majority. But I feel like, sometimes men with bladder pain syndrome are kind of sent down this chronic prostatitis road with all the problems associated with that. What are your thoughts?
So let's talk about the men versus women thing. That's actually one of these big IC myths, right? So we have always, in all of the literature, it always says that IC is most commonly started with a woman in her 40s. Now, when I was researching for the book, we actually found that article, and that statistic was based in one county over a 20-year span with only about a handful of patients, some of which were 20 years old, some of which were 70 years old. So that's where like the 40-year-old woman statistic came about. So if we fast forward to 2011, when we started to have the RAND Corporation did a study called the RAND IC Epidemiology Study. And that's where they actually studied 130,000 households, and they looked at the diagnostic criteria of interstitial cystitis. And that's where we started to see that actually some of the symptoms of IC were actually starting more in people's 20s. And the small subset of that research came out and looked at men, and they actually found that based on the current definition of IC, that we have right now, we'll go into that in a second, that the incidence of bladder pain or perceived bladder pain and urinary frequency and urgency, which are the two kind of hallmarks of the condition, the actual statistics of men versus women almost even out. So there's like 6% of the population is estimated to have, of women or to have IC, and then about almost 5% of men are to have similar symptoms. So really, I think we're probably talking about the same condition. And so if you think about it that way, then men should be sort of ushered into the same treatment protocols for chronic prostatitis as they are for IC. But I feel like right now that's not, chronic prostatitis patients get way more ushered into the antibiotic route. Well, women do too, but definitely more of the men do for a longer period of time.
Which of course is problematic in and of itself, because with the recent research, Grundy's paper last year showing that what's happening in the gut microbiome and gut health is so closely connected to
Yes.
bladder health. I mean, the fact that we've only recently acknowledged that the bladder has a microbiome, first of all, but anyway,
Right.
but if gut health is so connected with bladder health, and we're giving people lots of unnecessary antibiotics, how are we expecting them to get better? And we're not sending them to physio.
Right. Well, we'll talk about that. But there's right. But that's the whole thing. And then we can kind of get on this subject a little bit. But there was a recent article around here at the Washington Post, and there's like a lot of hype about this new DNA testing for the bladder microbiome, right? Which is a wonderful technology to have so far, but we do not understand yet how we can interpret those test results. And so I think we're sometimes getting a little bit too quick to be like, oh, that's a different bacteria that we see in there. IC must be an embedded infection. Therefore, we'll try these different antibiotics, and then we're just perpetuating the same problem because we don't yet understand that research. So I hope that.
No, I think that the tendency sometimes, isn't it, to chase the bright new shiny thing, and
yes,
it's
totally
exciting. I do think there's this. We have to kind of look at maybe the work that people like James Malone Lee are doing around those chronically embedded infections in the bladder line that are maybe not being picked up with MSUs or dipsticks. And I think that's a whole different minefield we can go down.
Yes,
but I think possibly for bladder pain syndrome, really getting the big rocks right, getting a good foundation in terms of pelvic floor muscle function, stress management, movement, bowel health, eating well, moving well, sleeping well, managing your stress, dealing with some of the central sensitization issues that can happen as well. I think those are really applicable to most of the people that we're going to be talking about today.
Absolutely. And even if, right, there is an infection part of that, then either way, we have to address all of those other things, because that system, the brain bladder system, has now been disrupted for so long that we need it to help it to sort of restore it normalcy. And we can do that as physios. So that's where I feel like we need to insert ourselves way more into the process.
Absolutely. And I think, I'm really happy to see, the tone in current research around bladder pain just seems to be shifting, that we need to be able to look outside the bladder, that if we're just focusing on the bladder, we're actually doing our patients a disservice.
Yes.
Which is kind of leading me nicely into talking about the role of pelvic floor muscle dysfunction in bladder pain, IC. It's really, for me, I think it's such a foundational aspect of recovery that we look at reestablishing good coordination. But I feel sometimes the medical model doesn't always, even though it's grade 1 evidence, sometimes the medical model doesn't always embrace that. What's your experience been around that?
Yeah, absolutely. I feel like the medical model is still very much bladder-centric treatments.
Yeah.
And when we're talking about a condition that only somewhat involves the bladder, then and might not be the actual root cause of the symptoms of the bladder symptoms that people have, then, it's no wonder that sometimes bladder-centered treatments don't help as many people as you would think that they would if it was truly a bladder condition. So, and then my big thing around this is that it's not like all medical treatments are wrong for IC. There is definitely a place for installations, for Botox to the bladder. There's all kinds of medical treatments that can help. But if we do the whole medical list first without coming into the pelvic floor part, then that's where we have a problem. And the AUA guidelines, which sort of the whole world follows actually, list pelvic physio as the first line of medical treatment and the only thing that's given an evidence grade of A. So that's when I get really frustrated at somebody that thinks they're doing the right thing, and then they're going to the urologist, and then they're going down all of the medications and the installations, and no one ever talks about the pelvic floor component. That's where I feel like we need to rise up and insert ourselves into that process a little bit more, however we can, in order to make sure that patients are actually getting the treatments as they should be listed in the AUA guidelines.
Absolutely. I think it's so important because, every medication is going to have a side effect, not the least of which, will be the financial burden that it's going to place somebody under. Whereas I think with good pelvic floor physio, which is also going to include, pain education, brain training, stress management, movement. It's not just about manual therapy for tender points for myofascial dysfunction or using magic wands or things like that. I think this is my frustration with our profession though, because I think we're really good at talking to each other about all of this. We could do a much better job of talking to both our medical colleagues, but also I think normal people, and really trying to spread the word. What is the risk associated with pelvic floor physio? Pretty low. Pretty low.
Pretty low.
Pretty good return in terms of cost, because I think for a lot of us, we do strive to promote self-efficacy. And, we're big believers in home programs and, and education. And I just think we're such an underutilized resource. And the evidence is there, but maybe the awareness isn't there,
Isn't quite there, yeah.
I really feel like a newer generation of urologists, though, are much more open to a collaborative approach. Has that been your experience? Are you finding that because they're running out of options to deal with, particularly with pain syndromes, any pelvic pain syndrome, be it bladder pain or pudendal issues or vulvodynia, I think they're finally realizing that, we have colleagues who actually may have a toolbox to help us.
Yeah, I'm definitely seeing that trend is definitely switching a lot. What I think is even more exciting is I think that more and more patients with interstitial cystitis are also starting to drive that conversation to their physician. I kind of think that that's a great symbiotic relationship there, where we're educating the patients are going to their urologist and asking for pelvic physio. On the other side, we're talking to urologists and all of the other healthcare practitioners and GPs. We can't forget about GPs too, because that's commonly where they're starting first, because they feel like they have a UTI. So I feel like there's a lot of work to be done, but I do feel like the tide is shifting a little bit into this new world. And I think the more that we sort of educate patients that pelvic floor dysfunction can cause all of the symptoms of IC, then we have a lot of room to work with that, and that kind of goes back to, well, is it overdiagnosed or underdiagnosed? I mean, I think if you look at the actual definition of IC as it stands right now, technically it's underdiagnosed, but where I feel like where we're missing is that actually, if you really take a look at people's symptoms, a lot of them, if not, the majority, are caused by some sort of pelvic floor dysfunction going on. And in that way, what do you really have? IC or pelvic floor dysfunction. And the reality is, by definition, you have IC pelvic floor dysfunction is present in 90% of people. So there you have it. You just need to go to a pelvic physio and sort it all out. It's really what you need to do.
We'll take care of all of it. It'll be fine.
Yeah, it'll be fine.
Yeah, you know, that there is hope, you know, and that there is resolution possible. It might not be an entirely straight line, you know, from A to B in terms of recovery. But I think just even to give people a toolbox for self-care and to say, okay, so you know you're sensitive to red wine, but you were at a party, you had a couple of glasses, now you're having a flare. The most important thing is not to panic, you know.
Right.
Let's calm down the nervous system. Let's wait for the storm to pass. Let's do the breathing. Let's do some self-release. Because I think, you know, putting the person back in charge again. There was a great quote on Instagram a couple of days ago that we don't treat body parts, we treat people. And to remember that there's the whole person attached to this bladder, to this pelvis, and to be able to bring in all those aspects of meaning from their lives, and really to empower them, I think, you know, instead of going from a passive recipient of medication or installation or whatever format, to actually getting back in the driver's seat and showing them how to take care of themselves.
Yeah, and being able to just have a lot of self-awareness and body awareness as to, you know, what is ramping you up. I feel like I spend a lot of time with my patients actually having them do a lot of just like self-reflection when you have a flare. Like we spend time talking about like, okay, like let's list all of the things that we did, like even 5 to 5 days before. And then let's see, has that been a problem in the past? Because I think understanding the flare but that's our job to help people see it though, because that we can't expect that patients are automatically just going to totally get it, you know? So I feel like as physios, we have to make sure that we're helping guide them into understanding themselves and then and having a strategy and a plan to prevent that in the future or catch it sooner. So,
and I think that really, I think, beautifully encapsulates this whole biopsychosocial model that we're always talking about. I think you just summed it up beautifully there. I would love to talk about the screening tool that you've developed.
Oh yeah, great. So, okay, so this is something that just came out of, we did a retrospective analysis of a bunch of basically our intake forms, and we had adapted some of our intake forms from the International Pelvic Pain Society. So we had different categories of bowel, bladder, sexual health, and orthopedic conditions as well. And we kind of looked, and my husband is a super physics nerd and did a ton of like, I don't even know what lines he did in regression analysis. I don't even know if that's the right word, but anyways, right. Yes. But he basically made a statistical analysis of all of the things that people were saying yes to. And then because we had evaluated them, we knew that they had pelvic floor dysfunction. And so we took the most common yeses to those questions. And then statistically, if someone answered three yeses out of the 10 most common questions that we had, then it's like 94% likely that pelvic floor dysfunction is at least a potential component. We're not saying that that's any like, oh, big diagnosis, but we're definitely saying that, oh, if you're having a challenge with hip pain or something, then pelvic floor dysfunction might be one of the contributing factors to whatever symptom you have: incontinence, tailbone pain, hip pain, anything like that. So it's been a really cool tool, and we hope to be able to do the opposite to catch specificity, right? To take normal people, normal quote unquote, but people without pelvic floor dysfunction, and then to have them fill out the same thing, and they should have less than 3 out of 10, right? So, and then see what percentage of it captures people that don't have that.
That's super. So what sort of questions are you asking in the form?
So all kinds, like, have you fallen on your tailbone? Do you have any incontinence? So there's, I think a big part of the challenge is that a lot of people don't associate some of the things that could be contributing to pelvic floor dysfunction with another symptom that they're having. So it's been really helpful for us, for people, especially in like the orthopedic world, that like aren't getting better. So let's say they've gotten 6 to 8 visits with their physio. They have really bad low back pain. That physio might not be super comfortable asking all of the other pelvic floor questions. So this is kind of a great tool to be like, oh, I did fall on my tailbone. I do have constipation. I do have a trouble emptying my bladder, you know, those kinds of things. And then all of a sudden it's like, ooh, maybe the pelvic floor dysfunction is also a component to your low back pain as well. And there's been obviously research to corroborate that as well. But at least it's another way for somebody that's not super well versed in talking about peeing, pooping, and sex like we all are, to help capture those people and get them thinking that like, oh, there might be some help for me in all these other areas of my pelvic floor. So
absolutely, I think that it's such a valuable tool to have out there. I wanted to touch briefly on some of the mythology around interstitial cystitis.
Yes.
Okay, so, you know, let's talk about how it's not just a disease for 40 plus women, but do you feel there could be a hormonal component, or do you often see it going along with conditions like endometriosis and pudendal neuralgia?
Yeah, this is a really interesting question, right? So there has not, as far as I'm aware, there has not been there has been a connection to some parts of estrogen being exacerbating symptoms.
Yeah.
But there hasn't been like, that's not been a single proven cause of IC.
Like a driver of it, yeah.
Yeah. So, but I will see everybody being very different in sometimes in their cycles, and endometriosis is a very common comorbid problem, as is, and pudendal nerve irritation is also a really big driver. And remember, the pudendal nerve has bladder afferents. So I actually just saw a patient the other day. She was coming to me for like a second opinion, and I actually think she has like clitoral branch irritation that's causing her urgency of the pudendal nerve, right? And she's been on Elmeron and all these other things, but no one's actually like looked at that as a potential cause, you know, and she has pain with arousal and some other kinds of things that might, you know, indicate that. But anyways, that's a little bit off topic, but she, so I think that estrogen and the different parts of your cycle can exacerbate symptoms. I think endometriosis is definitely one where I believe it's, I can't remember exactly the number, but I think it's in over 60% of people will have both. I don't know that that's exact, so don't quote me, but it's high, you know, and both conditions have pelvic floor dysfunction as a common denominator.
Well, all three, so, you know, I mean, because I often think with pudendal dysfunction, you know, it's very much a chicken and the egg situation, isn't it? You know, which came first, the pelvic floor muscle dysfunction or the pudendal irritation, you know?
Totally.
So I think it can get quite hard to tease out the details of it. But again, that's where sometimes, you know, yes, we want to be able to zoom in, but we also want to be able to zoom out and take that big picture overview. Let's talk about some mythology around the IC diet.
Yes.
I know that's something that you like to talk about.
I love talking about this because here's the thing. Yeah. So here's the thing. I think that because of where we started with IC, right, that it was a bladder condition, then therefore something that's going out of my bladder must be irritating the lining. That's sort of the myth around the condition, right? So the IC diet actually started with just a survey to a bunch of people that had IC symptoms, and they just said, what foods bother you? And that's where the IC diet list came out
all those evil tomatoes.
Right. So I think that, right, and I always am wanting to take the fear out of food with IC. Can't be scared to eat. Like that just, isn't a thing. So if you actually look at the research, then most IC patients or people with interstitial cystitis symptoms have only about actually 5 to 7 true trigger foods. And so the gold standard for figuring out which foods you're sensitive to is truly like an elimination diet. And sometimes that's difficult to do, and you need help sometimes to do it. And we can help people do that or refer them to a nutritionist to help them do that with some guidance. But that is really the thing. And then once you find those trigger foods, then you stay away from those and eat very healthy and helping to decrease inflammation. And you want to stay away from sugar and stuff like that as a foundation. But we don't have to take away huge food groups without any data for yourself. So my biggest thing is acid in doesn't equal acid out in our bodies. And so, yeah, so it's just like, that's just not how the biochemistry of what goes in our mouth works. So, and this is the other crazy thing. When I was doing the research for the book, they actually did a study on acidic urine and the pH of urine, and urine pH actually fluctuates throughout the day. And they were actually taking out people's urine, doing the pH, instilling it back in, and people had no idea. Like there was no correlation between symptoms and acidity of urine. And so if we look at that, I just want to make sure that as physios too, we have to be, sometimes we're the first ones to sort of bust that myth for people. And we can't always do it the first minute that they sit in our office, because if you have somebody coming in with that mindset, you can't just squash it. It's not like us being right and them being wrong. It's guiding them to sort of see for themselves, like, are you really that food sensitive? And some people are, and some people are. So I just want to make sure that we're not blanketly saying that there's a huge food sensitivity to people.
Absolutely. I think that's such an important point, because I think sometimes almost like a little bit of knowledge is a dangerous thing. So we know there's a huge correlation, don't we, between IBS and bladder pain syndrome.
Right.
I think a lot of people have heard that for IBS, you need to go on a low FODMAP diet. And that's the end of the story, where of course it's not the end of the story. You go on a low FODMAP diet for a very limited period of time to reset, and then you gradually reintroduce to see what your body likes and doesn't like. And then you listen and you obey those messages. Because I think if we, I think it was the Grundy paper from last year showed that women with bladder pain syndrome, IC, tend to have a much less diverse microbiome than women who don't. So we want to that we have this wide variety of, the probiotic and prebiotic rich foods that are out there, primarily plant-based, but, to give us that diversity, which is going to improve our immune system, which is going to be great for our mental health, all of which ties into, how we're feeling in our entirety. So I think it's really important that that's a key message that we get across, from this video, that it's not that you have to avoid all citrus, all tomatoes, forever. I would say it's probably no harm to stay away from things like alcohol, artificial sweeteners, added sugar, and smoking. But we should probably be avoiding those things anyway, most of the time.
Totally.
So I think that's a really key message, and it's one that I think you really explain beautifully in the book as well.
Oh, thanks.
So, yeah, no, absolutely. Is there anything else you would like physios or normal people who've stayed with us this long, but I get the feeling it's primarily physios at this point. What do you really want clinicians to know about interstitial cystitis, bladder pain syndrome?
What I want physios to know is that, and believe, is that there is a huge pelvic floor component to IC and painful bladder syndrome. And I want us to take ownership of being the medical practitioner that can help that aspect. And it can be huge. So I feel like sometimes we either refer out or go back to your doctor because I don't know what this is all about. And yes, we need to be working with a medical the medical team in a very close way.
Sure.
But we also have a lot of knowledge to give, both to our patients and to the other medical professionals that we're working with on what symptom generators are actually part of the pelvic floor, and help that way. So I really want us to make sure we take ownership of that expertise that we have, and not be so quick to, number one, think that IC is a bladder condition and that we need only like medical intervention. And once you get that under control, then come back to us. And it's not, we need to be doing that simultaneously, to help our patients the best, I think. So that's sort of what I want physios to do. It's what we talk a lot about in my course, and just like, we just need to take ownership of that and be confident in doing that.
Yeah.
You know?
And I think as well, just to also, if I could just add an addendum to that as well, that the physio, the pelvic rehab approach is not just about going in and doing trigger point release. It's about exercise prescription. It's about neuroscience and pain education. It's about movement with confidence. It's about finding out what the meaningful tasks are. It's about teaching somebody how to have a good bowel movement, how to use their breath as a tool. That's all for me under the umbrella of good pelvic floor rehab. And I think it's really important that it's, because sometimes to look at some of the papers that are out there, they tend to get very trigger point centric,
manual based.
It's a small part of what we do, and it's a means to an end. It's to create that window of decreased pain, so now we can increase confident movement.
Absolutely. And I feel too that, you know, what I hear a lot from physios sometimes is making sure that we don't practice outside of our scope of practice. And that honestly like blows my mind, because everything that you just said is in our scope of practice. It is. And yes, if we need to get a little bit more in the weeds on a food sensitivity, we need to refer to a nutritionist or a holistic other doctor, naturopath, or whatever you do. I mean, but we can still talk to people about that. We can present research on Elmeron to people. You know, we can tell them the facts. We don't have to say get off of the medication, but we can say, you know, this does only work for 30% of people. And if it's also causing you these symptoms, you need to go back to your doctor and ask them, You know, that is in our scope. And so I feel like that's another thing that we need to take ownership of.
I think that's another really vital point as well, that, you know, I think as physios, one of the things that we have the gift of is a bit of time with our patients as well. And that ability to create, I think it was Jason Silvernail who coined the phrase, that therapeutic alliance with them. So to be able to kind of, you know, just to go that little bit deeper, to be able to ask them about their sexual health, you know, and how all this is affecting, you know, that aspect of their life as well. Because maybe we're going to be the first clinician to actually ask about that. And to say, well,
or their mental health.
I mean, I think if we are going to be biopsychosocial practitioners, we have to look at the whole person and really not be afraid to do that, because everything that we've talked about for the past 40 minutes or so is coming from a deep bed of evidence. And no, you know, even telling somebody to come off dairy for 3 weeks, did anybody ever die of dairy deprivation?
Right. No, we're going to be fine. Everybody's going to be fine.
Yeah, you'll survive it. You will, you know.
You will.
And I think, you know, so yes, it's our confidence as clinicians. It's knowing the evidence. You raised a couple of interesting points during our chat as well about not just reading the abstracts of papers as well. Maybe read the whole thing just to get the full story, you know. Because it's important that we do embrace this specialty, because I really feel like good pelvic floor practitioners are a bit like unicorns. It's become kind of a trendy thing to say, I'm a women's health specialist or I'm a pelvic health specialist, but there's a lot of folks out there who maybe are not doing the deep dive. So I think it's an important thing. If you are going to call yourself this, do the work, read the papers.
Do the work.
You know?
And the whole work. Yeah, for sure.
Reasoning, you know.
Absolutely.
And also, buy the book.
Buy the book.
Buy the book. seriously, I just think it's a very, very useful addition to any clinician's library who is working in the field of bladder function or dysfunction, because I feel like the focus is very much on continence, and leaky bladders and, tenna and poison and all of that, But we have to really acknowledge how destructive bladder pain can be on somebody's life, particularly because there is a lack, I think, of awareness in the medical community as well as in the general population. So hopefully conversations like this will go some way towards addressing some of that, and just to realize that there are great resources like your book out there, and it's to not be afraid to ask for help if you're struggling. That's my soapbox over.
Yes, absolutely. Yeah. Right. That's awesome. I already went on a few, so we're good to go.
Nicole, where can people find out more about you? What's your website? Are you on social media?
I am. So my clinic is called Pelvic Sanity, and we're located in Orange County, California. You can go to pelvicsanity.com/blog. We have a blog where a lot of this stuff is. And then our website for our patients and the out-of-town program and all that kind of stuff. And then I'm on social media as Nicole Cozean DPT, and the clinic also has a handle at Pelvic Sanity. So people can DM us, and we have a patient-based group called Finding Pelvic Sanity. We use positive, practical, evidence-based information. So if there is so we moderate that. All of our therapists are moderating that quite a lot as well. So
fantastic. Excellent. And again, the book is called The Interstitial Cystitis Solution, a holistic plan for healing painful symptoms, resolving bladder and pelvic floor dysfunction, and taking back your life. And available from all good bookshops and my personal crack on Amazon. Nicole, thanks so much, and I'm sure this is going to get a tremendous response. So you can follow Nicole on social media and follow her work there. But thank you so much for spending this time chatting and for sharing your expertise with us.
Yay! Thanks, Michelle. I'm so happy that you asked me to do this. I'm so honored. Thank you.
Pleasure. Thanks. Talk soon.